Welcome everyone. My name's Kat Urban. I'm a palliative care specialist working up at Lismore and with an interest in fatigue research and member of the Fatigue Symptom Committee. I'd just like to start by acknowledging the traditional custodians of the various lands from which our attendees join us today and pay respects to those elders past, present and emerging. I myself come to you from the land of the Widjabul Waibul people of the Bundjalung Nation, and I want to pay tribute to the unique role that they play in the life of this region. So just a bit of housekeeping. The session is being recorded, so please can I ask everyone to just keep themselves on microphones on mute. And if you've got questions as they come up, can you type them into the chat, please, and we will address them at the end. So this is now the third in the seminar series on facing fatigue. And as I'm sure everyone is aware, fatigue is a very common and very distressing symptom that is faced by patients with cancer and also survivors. CST, the Cancer Symptoms Trials group, conducted a Delphi study, and both healthcare professionals and patients really think this is a priority area for research. And so as a result, this Facing Fatigue seminar series has been developed with talks from leaders in the field, people with lots of expertise in this area. And I'm sure that our talk today will be just as excellent as the previous two with our esteemed speaker. So I am delighted to introduce our speaker for today, Professor Sriram Yennu, who is joining us from Texas, where I believe it's 7 p.m. in the evening, Tuesday evening. So Professor Yennu is a professor in the Department of Palliative Care and Rehabilitation Medicine at the University of Texas MD Anderson Cancer Center. Since 2005, he has served as the chair of the annual Intensive Physician Board Review course in Hospice and Palliative Medicine, as well as the Interdisciplinary Conference in Supportive Care Hospice and Palliative Medicine at the MD Anderson Cancer Center. He is an established physician, researcher, and educator, and has been recognized as an American Cancer Society and American Association of Hospice and Palliative Medicine Research Scholar. He is the recipient of numerous awards, most notably the American Cancer Society Mentored Research Scholar Award and the American Association of Hospice and Palliative Medicine Young Investigator Award. He was the principal investigator of the recently completed RCT trial looking at dexamethasone for cancer-related fatigue that was sponsored by the American Cancer Society, and he currently has ongoing studies on the role of multimodal therapy as well as ginseng on cancer-related fatigue. He is also the lead co-editor, along with Dr. Eduardo Bruera, of the Handbook in Hospice and Palliative Medicine published by Oxford University Press, and he has numerous peer-reviewed and invited publications in high-impact journals across both palliative care and oncology. Professor Yennu has published and spoken widely on the subjects of cancer-related fatigue, sleep disturbances, pain, delirium, and also geriatric palliative care. And his other interests include hospital-based palliative care outcome research and education. His seminar today is around drug therapies for treating cancer-related fatigue. So I extend a very warm welcome to Professor Sriram Yennu. Thank you so much for being with us today.
Thank you, Kat. And I just wanted to thank everybody, all the organizers, including Linda James. And it has been a great pleasure to discuss about fatigue. I know this is a part of the seminar series, and I'll be discussing a lot about drug treatments, but we'll be kind of scanning through other treatments too, so that kind of discuss why drug therapy is so important and there's so much of research to be done. Before I start my presentation, I would kind of do some disclosures. I have no conflict of interest related to this presentation, and have some grant supports for fatigue and other research from various institutions. And also I'm a consultant for Pfizer for a cachexia study. So with that, let me get started. The first thing we wanted to kind of first do is try to characterize fatigue. The main thing I want to kind of discuss is the definitions that we want to use to characterize fatigue and the various causes. And then we will go on to see how we can assess fatigue in a regular clinical practice. and then focus on the management of fatigue, which would be mainly discussing about the drug therapies, as the others have been discussed or will be discussed in the later seminar sessions. Then we'll be also kind of outlining a little bit about the new treatment strategies for treatment of cancer-related fatigue, that is the combination therapy. So those are the things I plan to discuss in the next 40 so minutes. And we'll be having some time for questions, but don't hesitate to use the chat function. And in anything, don't hesitate to also unmute yourself if you have any difficulty understanding or listening, okay? So if you think about fatigue and other symptoms, it's quite common, especially in palliative care patients. And if you see patients receiving cancer treatment or having cancer, the frequency of fatigue is quite common and is as bad as 90%. But other advanced diseases also, such as end-stage AIDS, heart disease, chronic obstructive pulmonary disease, or renal disease, the frequency of fatigue is as high as in cancer patients. And this is very relevant because other symptoms that we commonly come across in terms of symptom control is pain. It is as frequent, but it is not as severe or debilitating in terms of its effect on daily activities or social activities, or in terms of its effect on cancer treatment. So we do address pain a lot. We do address nausea a lot because there are a lot more treatments available. But I think trying to understand that fatigue is quite ubiquitous in cancer and other conditions is something that you need to be kind of emphasized on this slide. The very interesting part of fatigue is that it is quite a vague symptom. And there are various terms used and in different contexts. Sometimes if somebody has trouble focusing, like having trouble to remember things, they use fatigue, but it is more in terms of relative lack of attention, unable to concentrate, poor memory, or having clouded memory or confused state. If they is fatigue in terms of trouble with sleep and or related to sleep, they are kind of saying that they are more fatigued and drowsy. And whereas if it is more of a physical issue, they are tired, but they feel weak. So there are various terms used. So if it is all related to the context, and if it is related to the psychosocial aspect, they are either feeling depressed or irritable. And if it is related to more vitality or lack of energy, then it is mainly feeling lethargic or tiredness or exhaustion. So various terms have been used, and sometimes they can be very important. And I'll be discussing later because some of the treatments may be focusing on the specific relative context. But first of all, let's discuss about what is the definition of cancer-related fatigue. And there have been several definitions, and the most accepted one is from the National Comprehensive Cancer Network here in the United States. And I think it defines fatigue as very distressing and persistent. And the most important thing is it's a subjective symptom, and it has basically different domains. That is, it can be physical, emotional, and or cognitive tiredness or exhaustion. And the most important cognitive aspects of the fatigue is that it's not proportional to the recent activity and it interferes with the usual functioning. So if you have all these things, then it is definition of fatigue fits in. Now, in cancer patients, which I'll be focusing more because a lot more research has been done, fatigue is as frequent, but it's more common in palliative care setting. And the most important thing in palliative care setting is that it is present throughout. Like, it doesn't kind of get worse after chemotherapy or radiation therapy, which is kind of during the treatment. But it is it is kind of present throughout the trajectory of the illness in advanced disease. And the most important thing is that it is severe and very debilitating in palliative care settings. Whereas in patients who are getting treatment, like those who are getting combination treatment of cancer, chemotherapy, radiation, or chemo radiation, and targeted therapy, the fatigue is common, but it is usually after the treatment lasts for 4 to 5 days and gets a lot better. Mind you, if you are getting targeted therapy or immunotherapy, you do have fatigue, but sometimes it may be related to the endocrinopathy that patients may be having, or maybe related to the combination immunotherapy they are getting. So it is more frequent then. So that's something you want to think about. So I like this diagram, basically a graph showing the frequency of symptoms in the last 6 months of life. And this study was done in the Ontario in Canada. Basically, there's the whole cancer system, and they did collect the database of more than 3,000 patients. And they looked at the symptoms in the last 6 months in the outpatient setting. So if you see the blue line, which is basically the tiredness or fatigue, usually it is moderately severe, that is 4 on 10 on the Edmonton Symptom Assessment Scale. And usually it gets kind of worse as you go by at the end of life. Whereas pain, which is more of a purple line here, and usually it is more mild to moderate, and then actually doesn't get worse. It's kind of on a flat line. The symptoms which kind of very much go in the same path as the fatigue are the appetite and feeling of well-being. So it seems to be very closely related to the quality of life get worse as the patient has advances in their illness. Now, why do you really need to bother about fatigue? Or why do you really need to treat fatigue? So there has been more research lately, and they found that it is directly proportional to the performance, ability to get treatment, but most importantly, the quality of life and their ability to be having productive work life or social life. So that's something that needs to be taken care of. And usually patient tries to postpone or try to avoid asking their treating oncologist or the treating physician about fatigue, because they feel that it is pretty normal and it is a routine part of getting cancer or treatment. So they just say that, let's kind of focus more about getting the tumor size control or getting the tumor markers control or getting pain control, which seems to be more urgent, but these seems to have more impact. So that's the reason it is better to treat fatigue versus not. Now, there is something new that is going on. Before, they were saying that all cancer patients get fatigue, and doesn't matter when in their trajectory the fatigue does occurs, and it is the same. But nowadays, it's kind of slightly more. There is a more new thought process that is going on. So patients who are in the early cancer or those who are getting active cancer treatment, they belong to a different category of patients, and they cause maybe slightly different. So this basically slide shows that those who are getting chemotherapy or targeted therapy and radiation therapy, the causations are more related to the inflammation or the cytokines. It may be related to the psychosocial symptoms because they are worried about the cancer diagnosis, the treatment, and what else they have to deal with it. And in addition to that, the cancer treatment affects their cancer cells, but also other immune cells in the GI tract and in the brain and other parts. And then that can increase the inflammation and other reasons that the patients, the neutrophils and other things that really make the fatigue worse. Whereas in patients with advanced cancer, usually the problem is not just due to the treatment, but it also is due to several other factors. The cancer-related symptoms such as depression, anxiety, weight loss, the use of medications, including opioids, the anemia, all of these can play an important role in addition to this, the inflammation. So that's the reason what we see is in cancer patients, especially in advanced cancer patients, the fatigue is more persistent and debilitating. Whereas in cancer survivors, the research is pretty easy to do, very simple, but usually the pathophysiology may be slightly different. It may be mainly related to the psychosocial aspect or deconditioning. There's not much role of the cancer treatment because they are way away from the cancer treatment about 1 to 2 years, and there's not much role of other cancer related symptoms like weight loss or anemia, and a lot less of the metabolic causes. So something that you want to think about. So how is fatigue caused? And I think I just don't want to bore you about the mechanisms, but there are several theories that may be related to fatigue. But this one theory by Dantzler and others basically giving importance to inflammation and the endocrine axis. So most of the time, whenever you're getting cancer treatment or you have advanced disease and the cancer is out of control, inflammation takes an important role, like mainly inflammatory cytokines, which play a role are the the IL-6 and IL-1 seems to be very much closely related to fatigue. Other important inflammatory cytokines are the TNF-alpha and the receptors. So these are basically activated, and these are in the periphery and in the brain, and they can travel to the brain through the blood-brain barrier, through the choroidal plexus, and affect specific areas of the brain, mainly the hypothalamus, amygdala, hippocampus, and basal forebrain. And these are the places where the symptoms are expressed. So the main symptoms we kind of express is the fatigue, but also the other symptoms like pain, wasting, and cognitive impairment, anxiety, depressions. These are the areas. But the body has a very good mechanism to counter these symptoms. And this is the hypothalamic pituitary adrenal axis. And these are activated. And that's a reason if patients are having chemotherapy or treatment and they are in the early stage, these symptoms are fairly controlled after this activation of this normal innate mechanism. But in advanced cancer patients, usually this hypothalamic pituitary adrenal axis doesn't really work properly and it is not modulated well. So usually the symptoms are not that well controlled. So that's the reason why the symptoms are more severe, persistent, and constant in patients with advanced cancer. So that is one way, but the current pathophysiology guidelines say that, in terms of the causations, immune mechanisms or inflammation plays an important role. The endocrine axis plays an important role, but also there is more thought about the causation, that is the mitochondrial metabolic function dysfunction. And all of these can be and are controlled by the genetic mechanisms. So whereas some patients are more at risk of fatigue versus other because of the polymorphisms in certain important genes, including the interleukin-6, TNF-alpha, and other genes that they have been finding out. But what is more practical, in addition to these pathophysiologic mechanisms, is the cancer-related symptoms that are related to it. So if the patient has more fatigue with anxiety, depression, they are more likely to have persistent fatigue. Those who are getting cancer treatment, like the cytotoxic, they are more likely to be more fatigued. Whereas if they are more disabled or debilitated, they are more likely to be fatigued. All of these can cause fatigue, but also are resulting of fatigue. So that's very important that if you see these symptoms, in addition to fatigue, if you treat them, then the fatigue also may be slightly better. In addition to that, if you treat the causes like the inflammation or any dysregulation of the endocrine axis or the mitochondrial dysfunction, then you may be also able to help the fatigue. The reason why I wanted to explain to you these things is because drug therapies mainly should be focused on trying to target these causative mechanisms. The tragedy of fatigue in cancer patients is that it's not just one mechanism that is abnormal. There is a combination of these mechanisms. Therefore, it is important that you can find a design a drug that really targets all these kind of mechanisms, then it would be ideal. But right now we are where we are. We are trying to find targets for each individual causation. And that's the reason we are finding some challenges. So that's the reason I wanted to emphasize on this. But let's go back to the clinic. So you need to know how to really assess fatigue. We can ask patients about their pain and their different causation of pains, but also the severity and other dimensions. The same way you can ask patients about the severity of fatigue, but also some dimensions. The dimensions is a part of the definitions, like there are different dimensions such as the cognitive dimension, the psychosocial dimension, the physical dimension. Mind you, they are not that they come exclusively, but they come in combination. One of them would be more predominant than the other. An example is that the patient may have physical fatigue, but they may have a component of psychosocial and the component of cognitive. So you need to look at which is the predominant dimension and then think about it. And sometimes you may have fatigue severe, but it may not impact them in terms of function. Then you need to think about, do you really need to treat the patient or really work up? So you need to think about various aspects, including the severity, the dimensions, and the impact on a given patient, whether you need to work up. For instance, the patient is having terminal illness in the last few days of life. Maybe the fatigue may not be the most predominant thing that you want to tackle about. Maybe say something else. So you need to think about which is the most important thing that the patient's perspective that is important to really take care of. Regards to the workup, it's also important that you don't do a whole bunch of battery of tests costing the patients a significant amount of money, rather than see what is the symptom, what is the dimension, and then look into the specific treatment. For instance, if the patient is anemic, then you do further workup, and should be relevant for that given patient. For instance, they are getting cancer treatment. Maybe it is more relevant to do a battery of blood tests to look for the causation of fatigue. The same way is if the patient is having polypharmacy, a lot of medications can cause fatigue, including the most commonly used in cancer patients, such as opioids, the antihypertensives, the muscle relaxants, and the benzos. All of these can play an important role. Function is another important thing. Mood is another important thing. Nutrition is another thing. Infections, all of them can contribute. The most important thing in the investigation should be trying to figure out, is this fatigue reversible or not? And that's the reason you want to kind of work on these investigations. Let's kind of look at what is the current level of understanding about treatment. We discussed in the previous slide about reversible causes, like some of the reversible causes are early cachexia, anemia, infection, poor oxygen levels, that is hypoxia, hypogonadism, depression. If we can treat them, if we are fine early, and that is kind of, there are some effective treatments for them. So always think about treating the reversible causes or the underlying causes of fatigue. Then if you do not have effective treatments or related causes, then think about non-pharmacological. It's not that, if you have specific treatments for a given cause of fatigue, you don't think about non-pharmacological, but you need to go in that direction. First, treat the reversible causes, and also think about symptomatic treatment. But in most instances, our patients, you really figure out the cause or may be able to find a cause, but still the fatigue is not controlled, then you still go on to the symptomatic treatment. And based on the evidence right now, I think we might have already discussed, is non-pharmacological has the best evidence. And then comes the pharmacological therapy or the nutraceuticals or the complementary treatments. So among the non-pharmacological, I think the best level of evidence is the physical activity or exercise. And there are various levels of physical activity that are important. One is the aerobic or resistance exercise. Then there is Qigong, or there is yoga. Then there is psychological interventions. The most important is the cognitive behavioral therapy. Then mindfulness based stress reduction therapy has also high levels of evidence, or level 1 to 2 evidence. Then there are other treatments like the psychoeducational interventions, the massage therapy, and among the others. But there is also in palliative care patients something called as energy conservation, basically trying to ask the patient to use the highest amount of energy for the most important meaningful activities, like meeting their family members, or trying to kind of having to spend some time with their children or grandchildren. So those are the things that can be used, like, and they have good evidence. The amount of evidence for the pharmaceutical and nutraceutical is very limited, and we will be discussing all of them in more detail. But I just wanted to give you an overall perspective about what is available regards to the treatment of fatigue. So, regardless of any specific treatment, there are some things that you want to think about in kind of managing fatigue. One is helping the patient sleep better. If the patient is able to sleep better, the fatigue also will be a lot improved, because it's one of the most important symptom that is associated with fatigue. And the most important thing you can think about in patients who are fatigued is sleep hygiene. One is avoiding caffeine after 3 p.m. and having a very conducive atmosphere for sleep, like it should be dark, quiet, comfortable, away from the blue light or the cell phones or other thing, mobile phones. And the other thing is trying to avoid as much the afternoon naps, which is very common in patients with fatigue. A lot of times, these patients are fatigued, and they usually are trying to sleep in the night. They're unable to sleep, so they try to be very drowsy and in the morning, and then they sleep for about 3 to 4 hours in the afternoon, and then they go on to not able to sleep at night. So it's a very vicious cycle. So the best thing is to avoid sleep afternoon naps, but there is more now thinking that it's okay to be having a power nap before 12 o'clock. So you can tell the patient around 11:30, 12, take a power nap for about 15 minutes, and that should be fine. So that is the more recent thinking about sleep. And then there is also the stimulus control that we discussed. Now, the other important thing is proper nutrition and hydration. So a lot of the patients, advanced cancer patients specifically with fatigue, have weight loss and muscle loss and fat loss. Asking them to eat the correct amount of nutrition content in terms of calories, fat, protein is important. And what we all normally advise is ask them to eat 5 to 6 meals, which are small and dense. A lot of times we talk about eating junk food, which is like, McDonald's, other things which have high levels of calories. So that's something you want to discuss with the patient in terms of managing their fatigue, is eating these high dense food. And some of the amino acids or proteins have high risk of gaining back the muscle. That is the arginine, glutamine, and leucine based products. So it is important to consider that. And the most important thing that we oftenly ignore is using an interdisciplinary approach or a multidisciplinary approach. For fatigue, especially, you need to involve a lot of disciplines. And the most important is nutrition. Counseling and nutrition counseling is very important, and you need to involve the team members there. Now, let's go on to the most important and the most evidence-based treatment for the fatigue, and that is exercise or physical activity. And mind you, there are several meta-analyses or randomized control trials, guidelines. All of them point to that fatigue helps, the exercise helps in a lot of symptoms, including quality of life, fatigue, but also helps the physical strength and also some of the triglyceride levels and body fat. And as I said, the evidence for use of exercise is good. And the best evidence is those patients getting cancer treatment, whereas those after cancer treatment, the evidence is a little bit weak. And for patients with advanced cancer, the evidence is even very poor. There is insufficient evidence to prescribe exercise in advanced cancer at this point, because of the number of negative trials and the limited positive trials in advanced cancer. Whereas in patients with who are receiving treatment, and who are in the early stage, there are good studies, and there is a good amount of recommendation from various organizations, including the the MASC, the ASCO, and the other cancer agencies, which was to prescribe exercise in those receiving cancer treatment. For after cancer, usually cancer survivors, it is less. And in advanced cancer, there's still a lot more studies to be done. The only thing with physical activity and exercise is that it is the user dependent. Like, there are some patients who would be very much interested to do the exercise, so they will be benefiting a lot. A lot of the patients may not be adherent or willing to do exercise, so they may not benefit a lot. So it is user dependent. So something that is important to think about. And the amount of benefit or the effect size is only about 0.30, which is very less. So it is, you need at least effect size of 0.7 or more to be saying, oh, this is a very good treatment. But that's the side effect, the concern. And a lot of times patients are not adherent to exercise. So that is another important thing. The other thing that is the prescription of exercise is a problem with exercise. You need to have the patient do 30 minutes for 5 days a week. So a lot of the patients may do it, but they may not be adherent during various times and phases. So it requires a lot of motivation on the part of the patient, but also that they should not have any other concerns related to the cancer or treatment. Like if they have recent surgery, then the exercise get affected, or having bone metastasis or thrombocytopenia. So you need to have some help from the interdisciplinary team, like the physical therapist, to help you with that. Resistance exercise also good, that you can do it 20 minutes 2 to 3 times a week. But again, the adherence is a big issue. And the most best evidence is in, again, those who are receiving cancer treatment, advanced cancer patients, less amount of evidence. And the other important thing is that there is not much difference in benefit in terms of supervised versus home-based exercise. So you can ask the patient to consider either of them, and they can get during treatment, and it has been found to be beneficial. Mindfulness and also other mindfulness-based exercises like Qigong, there is a growing amount of evidence. I think it has good studies, and it showed not only in improving fatigue, but other symptoms. And basically what it does, it helps with the concentration, relaxation, meditation, breathing regulation, body posture, and movement. So Qigong is another body, exercise-based intervention that has shown some evidence in terms of treatment of fatigue. The other treatment that has been discussed in a different session is cognitive behavioral therapy. Again, it involves a very active intervention for the patient. They need to actively able to basically identify the negative or bad coping mechanisms, and develop strategies, including changing their activity scheduling, their behaviors, and also do some active things like biofeedback and breathing exercises, and jot down them. And it is an active thing, and it requires at least 6 weeks of intervention. And so cognitive behavioral therapy, this regards to its evidence, it's more in cancer survivors rather than in cancer patients who are receiving treatment. There is very limited evidence in advanced cancer patients. So one thing that you want to think about, so if you have a cancer survivor, they are more likely to adhere to it better, and there is a better evidence compared to advanced cancer patients. Now, having discussed that, in advanced cancer patients and other patients like exercise, the adherence is pretty low. And again, with the exercise, the duration is a challenge. And in patients who are actively getting treatment, having complications, it is a problem. So that's something you want to think about. And in advanced cancer patients, the other option is if somebody is anemic, transfusion has a good role, but we have very limited studies. And from a study from Dr. Mercanti, they found that if you give a unit of or a point of blood transfusion, you'll have a better improvement in fatigue scores for at least 2 weeks. So that is a very limited studies about it, but transfusion has a role. But erythropoietic agents have major concerns of safety. And mainly the main concern of using erythropoietic agents is about increase in tumor size and thrombovascular events. So that's something you need to be thinking about, not using them for fatigue. So that's something that we need to emphasize regard is the safety. Acupuncture is another more advanced level of evidence in terms of benefit. And there have been more studies lately. And acupuncture is more beneficial in patients in receiving cancer therapy because that's where the evidence is. There is weak evidence for its use in patients who are cancer survivors and very limited in advanced cancer patients. Let's focus a little bit more on the pharmacological therapy, and then we'll also discuss some nutritional agent, nutraceutical agents too. The best studied drug therapy in cancer patients is methylphenidate. And mind you, it was way back in 1980s and 90s, there have been a lot of studies on use of methylphenidate for opioids-induced sedation. And actually, it has a level 1 evidence in terms of benefit. It also has been used for depression, and there are some positive studies. And also, there has been used for hypoactive delirium. But a lot of times in clinical practice, we try to avoid using of the psychostimulants in delirium because most of the patients are having either mixed or hypoactive delirium, and then it usually changes into hyperactive. So it is not that helpful. Whereas the use of psychostimulants in fatigue has been a great interest for a lot of us. The way the methylphenidate works is that it can affect the dopamine and non-adrenergic pathways in terms of uptake. And the other ways it can help the fatigue is through its effect on depression, cognition, and sleep and wakefulness. So those are the things it can work. And there has been a lot of studies, not just on methylphenidate, but also on modafinil and its isomers, that the R-modafinil. And the interesting part of most of these studies is that they were done with a very good in terms of quality. And they basically compared with active placebo, which is they basically used a matched placebo. And a lot of times, these medications, that is the psychostimulants and modafinil, armodafinil, improved fatigue in a lot of patients. But the main issue is that placebo also improved fatigue. So when they compared the placebo with the active agents such as methylphenidate or modafinil, armodafinil, a lot of times there was no significant difference in terms of improvement of fatigue at the primary outcome. And they had used different agents of methylphenidate. Some of them used just the short-acting methylphenidate. Some of them used the sustained release or long-acting methylphenidate. some used dexamphetamine, and some used the other agents that have been used include the modafinil, and the doses have been varied, and the duration of treatment has been varied as detailed in this table. The most important thing is that there was benefit in terms of improvement of fatigue, but was not significant compared to placebo. A lot of them looked into the side effect profile. The most common side effects that we see with methylphenidate are dizziness, jitteriness, and some of them say that there is also thrombocytopenia, but none of them was significantly different from placebo. So though they have some side effects, but when they compared with placebo, there was not much different. And there was a meta-analysis done way back in 2011. And what basically does is that there were about 5 studies they did compare with, and this was the team from UK, Ollie Menton, and their team with Pat Stone. Basically, they found that it is favorable compared to it favors treatment compared to not treatment, and the effect size was about 0.28. I think we did a recent meta-analysis for more than 14 studies actually, and the effect size is about 0.05. So the more and more studies are pointing out that it is less and less effective, or it has efficacy in terms of treatment of fatigue. So let's move on to the other common nutraceutical that has been in research or in news lately is the use of ginseng. There are various types of ginseng that have been used in eastern part of the world, and also in the Wisconsin area in United States. And basically, they prepare this product by drying or bleaching the root. And there are various types. The American or ginseng is also called as ginseng quinquefolius. Then there is the Korean or the Asian ginseng, which is excuse me, which is the Panax ginseng, and also the Siberian variety, which is the Erythrococcus synthecoccus. So the way the ginseng works is, excuse me, is through its main active ingredients, such as RB1 and RG1. And these are ginsenosides, and the ratio varies in the American versus the Asian ginseng. And that's how the pharmacological effects also are different. The most important thing is it works in the, mainly in the CNS by a stimulant-like action, and has effect on the cognition, but also has effect on the anxiety, depression. There have been some studies, mainly basic science studies, on its benefit on pain and inflammatory cytokines. And the main action is not just on fatigue, but also other symptoms. And the most other symptoms that it seems to work is memory, cognition, but also the psychological symptoms and inflammation. Now, there was a very good study by Barton. Actually, this is the second study she did in cancer patients who are getting treatment. And what she found is that they used, with the use of ginseng, American ginseng, 2,000 grams, that is 2 grams of ginseng, 2,000 milligrams or 2 grams of ginseng over the period of 8 weeks. She found that the team found that there was a significant improvement of fatigue with a validated tool called the multifunctional fatigue symptom inventory. They also replicated these findings with other tools like the POMS. So the interesting thing about this study is that in those patients who are getting cancer treatment, there was an important improvement even at 4 weeks, whereas in other subgroups, it was week 8. And the most important thing is that the most concerning thing, what we see with ginseng, is that we are worried about its interactions with other cancer treatments and also the side effects, and they didn't report any difference compared to the placebo. And this was done way back in 2013. Our team here at MD Anderson did a study using Asian ginseng. We used a dose of 800 milligrams because most of the studies done at that time had used about 200 milligrams, and we wanted to use a higher dose, and it was used in certain settings in Korea and others. So we used a higher dose of 800 milligrams after doing a pilot study. And we used this for about a month time. And there was a significant improvement in fatigue using the ginseng after 1 month. Usually a 3-point change on the FACIT-F indicates clinically relevant improvement. And we saw a 7.5 points improvement in terms of improvement of fatigue using ginseng. But placebo also improved by more than 6.5 times. So there was not much difference between the groups, though there was a clinically relevant improvement. There was not difference compared to placebo. And this was also reflected in the ESAS scores, ESAS fatigue scores. And so we wanted to kind of state that based on that study, there was improvement of fatigue, but I think maybe the dose was not higher enough. So we wanted to do further studies. So we are working on another study right now. And but the basic conclusion from that study was that it was not superior to placebo after 4 weeks. There was a recent study, and which was published way back in 2020, and about using Korean ginseng, and they used about 2 grams or 2,000 milligrams for 16 weeks in patients getting FOLFOX-based therapy in colorectal cancer. And they used a validated tool called the brief fatigue inventory. What they found was that there was an improvement in the global brief fatigue inventory scores, and after 16 weeks, and it was clinically and it was statistically significant. So that was their conclusion. But one thing they were worried about or concerned about is that there was a higher frequency of neutropenia and side effects in this group. We did not see these side effects in the lower dose, but with 2 grams, there was a higher incidence. So that something is of concern, and this needs to be replicated. So the effect sizes for using of ginseng based on our recent meta-analysis is about 0.47. But again, we kind of mixed up both Panax, ginseng, and the American ginseng together. So we need to do more studies on these individual ginseng because their ginsenosides are different, and they may be slightly different in terms of mechanism action. So we are still in conclusion about whether to prescribe it or not. But thinking about using, if the patient wants to use, right now the better evidence is for using the American ginseng, that is 2 grams, using for at least 4 to 8 weeks. That is the evidence in terms of it. Then there is another nutraceutical called guarana, which is mainly seen in Amazon basin, and it has various alkaloids including methylxanthines, theophylline, theobromines, terpenes, flavonoids, and has also some anti-inflammatory activity. So there's one group in Brazil that has done multiple studies and they found improvement, but we need further studies to validate these findings and consider to use it. And also the characterization of guarana is also much needed. Then there is the use of steroids. And most of the studies on the use of steroids is in patients with advanced cancer. And the basic action is through inflammation. and also its action on the hypothalamic pituitary axis. And the most of the doses they used is about 8 milligrams per day. And that's none of these studies, other than the later studies, were done using validated tools. So we did this study using ginseng, dexamethasone as compared to placebo, and we did for about 2 weeks. What we found that the dexamethasone arm not only improved fatigue compared to placebo at day 8, but also at day 15. And the most interesting thing what we found is that it can help the physical part of the fatigue a lot more, and compared to the emotional or the psychological aspect of fatigue. And when the most other thing we found is that there's not significant difference in the side effects, because using steroids, especially for a long term, there is more concern for side effects. At least if you are using for 1 to 2 weeks, we did not find any significant side effects with this group. One thing we wanted to kind of point out is that in addition to the study that was done in 2013, there were studies in 1980s that had used steroids. And the only challenge is that they did not use any validated tool for fatigue. So we are still a long way to go to really recommend patient to use it, because we still need to figure out how long we can do, and the mechanism, and the target patients. But based on what we have now, using this dose of 8 milligrams for a short period of time with physical fatigue may be something considered. There was another study by Paulson, but it was mainly a secondary outcome for a pain study using steroids, using methylprednisolone, and his team also found benefits of using the corticosteroids. And I just wanted to point out some of the results of the meta-analysis we did. We found that there were about 5,223 patients we reviewed in 34 studies. The interesting part of that meta-analysis that was found that we did not find any of the studies to be having any beneficial effect. Groups of studies like ginseng, guarana, magistrol, mistletoe, psychostimulants, SSRIs, though there was studies in a higher frequency, we did not find any significant reduction. And most interesting part was about the psychostimulants. We found some benefit with the corticosteroids, but there were only very few studies done. So we definitely need more studies, and definitely need do in a very well-characterized patient population. And based on what we know, that we do have some nutraceutical and pharmaceutical intervention trials, but most of the time the effect size is 0.29 overall. And we could not make any decision about whether to recommend, unless it is a specific situation where the patient can given trials of corticosteroids in advanced cancer for a short period, or using of psychostimulants if they have other symptoms like depression or drowsiness, where the evidence is a lot better for drowsiness. So we think about that. The other thought process is using combination therapies, because any single agent may not target all the mechanistic actions. So thinking about targeting both the physical fatigue, the psychological fatigue, like using corticosteroids with physical activity, because physical activity can focus a little bit more, not only on the physical symptoms, but also psychological symptoms, whereas dexamethasone can focus a lot more on the inflammation. So we did a recent pilot study using dexamethasone 8 milligrams with exercise. Dexamethasone was given for 7 days and exercise for about 4 weeks. What we found that both the 4 milligrams dose twice daily and 8 milligrams dose twice daily with exercise, when we tried to do that, had improved fatigue. And this was a lot stronger in terms of the effect size compared to just using dexamethasone alone. And we are currently also doing a combination study of using exercise with methylphenidate. And we hopefully will be completing the study by next year, and we'll be having results about this combination of combination therapy. So to conclude, the treatment for fatigue is very complex. Right now, the goal is to treat the reversible causes by finding them out as much as possible. If not, the best evidence is on non-pharmacological treatment and integrative interventions, because not only they have better evidence, but also safe, inexpensive, and they have minimal interactions. There are some pharmacological agents which can target the mechanisms, but I think we still are in search for new clinical trials. And the best exciting part of it is that thinking about using combination of various treatments, because they can target all the mechanisms or most of the mechanisms that cause fatigue. With that, I conclude my presentation, and thank you for your attention, and I'm happy to take some questions.
Wonderful, Professor Yennu. Thank you so much for that very comprehensive talk. There is a question on the chat, if I'll read that out, from Vanessa Jensen. So I think this was around the mechanisms of fatigue. So Vanessa asked, do you know or think that these mechanisms of fatigue can persist for long-term cancer survivors, or would there be other pathways or reasons in that patient group?
Thank you, Vanessa. I think this is one of the area of research. I think, what we have is some pilot studies, but studies to look at the various mechanisms at different trajectories, because that would be something very helpful. We know there are some known mechanisms, but there are very limited studies that are trying to use these biomarkers in different trajectories and looking at which are present and which are getting worse. So that's the area of research right now. And in cancer survivors, the general thought is that the mechanisms are slightly different because there is less inflammation compared to advanced cancer patients. And there is a lot more psychological symptoms because they have a lot of anxiety, depression symptoms. So that can contribute. So, but if you look for the level of evidence, there is still a lot more studies to be conducted.
Thank you. I've got a quick question. Sorry, I know that time's nearly up, but I was really interested in what you said about exercise and steroids combined, because I guess my kind of practice is, suggest exercise to the weller ones who are earlier in the trajectory and then use steroids when they sort of start to fall off the perch. But I guess I wonder if maybe combining the two earlier, giving the steroids so that they feel a bit more energetic, so that they're able to do the exercise, to do the steroids as a brief intervention so that they can then continue the exercise. Is that sort of the better patient group?
Yeah, I think you need to be very careful trying to manage the benefits versus the side effects. Physical activity is good, but a lot of patients cannot be able to adhere to the physical activity or able to start it because it's like a catch-22. They're already tired. How can you exercise? So you need some booster or adjuvant or something that jumpstarts a thing. And the thought is that if you give the steroids for a week or so, like you get steroids for nausea management in patients getting chemotherapy. So the same way you can think about using it as a gem start or a adjuvant, so that the patient can start their exercise and sustain the exercise better. So it is that thought process rather than giving the steroids for a long term and then causing myopathy and all the bad side effects related to the steroid. So it is more like what you use for cancer-related nausea management, or that's something you want to treatment-related nausea management, CINV. That's how you want to think about the use of steroids with physical activity, because in sense they kind of are antithesis to each other. So you want to kind of use their benefits against each other.
Thank you. Tim Luckett had a question around perhaps there's better evidence for the non-pharmacological management strategies because they have not had to complete with placebo effect in the way that the drugs have.
Yeah, I think one of the thing about the non-pharmacological strategies is their safety. Not that they'll be wasting, if it's not benefiting, they're wasting 6 or 10 weeks of their time. That is still a side effect, but most of the time they are not having these side effects like using of psychostimulants or corticosteroids because of the thing. And the most important thing is that most of the studies for non-pharmacological thing is either by wait list control or the challenge of having a very good active placebo, because that is the thing. So there is a good argument can be made why non-pharmacological agents are more effective compared to that. The other third problem with non-pharmacological agents clinical trial is that most of the studies did not use fatigue as a screening criteria. So they used to do a study and then the patients can be followed up for a 6 months to 1 year period, but they did not use fatigue as a screening criteria. So that could be one thing that can be critiqued about. So, but overall, if you see, there are a lot more studies and there is good evidence about its benefit compared to safety issues.
Wonderful. I think we're a bit over time. Thank you so much for that really interesting talk and lots of food for thought there. And thank you everyone for attending as well. Just a reminder, if anyone is interested in being part of the fatigue subnode committee to help sort of further research, then you can email cst@uts.edu.au. And there is a web page for the next Facing Fatigue seminar in December, which is through the UTS website. And I think, Linda, you were going to share that link in the chat so people can see that. And otherwise, I think, Sriram, at the start of your talk, you did have is there an email or a website where we can follow your research?
Sure. I think you can definitely, I am very happy to collaborate if there is any question about any of the aspects about fatigue research, especially pharmacological therapies. You can email me. This is my email address, syennu@mdanderson.org. Or you can email any of my faculty here at MD Anderson, supportive care or palliative care team. Then they can connect to me. Or we have a whole lot of researchers here at MD Anderson. We can connect to the specific person because each may be doing something slightly different. Some of them are doing some basic science research, some of them doing in the mouse model or rat model. So it all depends on whatever, and I can help you to direct to that relevant person to help your research and collaborate.
Wonderful. Thank you so much for that. Thanks for sharing that with us. And again, thank you for your great talk. Hope you enjoy the rest of your evening.
Thank you very much, Kat. And thank you, everybody, for able to attend it. Okay, thank you. Take care.